Welcome to the Deep Dive. Today we're looking at a really interesting tool in the GI world, argon plasma coagulation, or APC.
That's right. It sounds maybe a bit complex, but it's basically using argon gas and electricity to treat tissue.
And we're diving deep thanks to Dr. G.S. Raj's excellent YouTube series, specifically his video HCC 1472 Lesson 11B1 Hemostatic Devices APC. He really breaks it down.
He does. It's a great resource.
So our goal here is to get a handle on this thing. What exactly is APC? How does this non-contact thermal therapy actually work? And maybe most importantly, why are things like precision and prep so critical?
Good questions. It's definitely a technique where details matter.
Okay, let's start there then. What's the core problem APC is designed to solve inside the body? When does a doctor say, this calls for APC?
Well, it really boils down to two main jobs. Ablation, that's essentially destroying unwanted tissue, and hemostasis, which is stopping bleeding.
Okay, stopping bleeding. Big bleeds. Small bleeds.
Good point. Critically, it's for small vessel bleeds. Think capillaries, tiny little surface vessels.
Yeah.
You wouldn't use this for, major artery bleed. That needs a different approach entirely.
Got it. So precision bleeding control, what about the ablation side? Where do you use it to destroy tissue?
A really common use is after taking out a polyp, especially with endoscopic mucosal resection, or EMR. You might use APC to treat the edges, sort of clean them up thermally to reduce the chance of the polyp coming back.
Makes sense, like cauterizing the base.
Kind of, yeah. It's also used a lot in managing Barrett's esophagus. That's abnormal tissue in the esophagus. APC can ablate or remove that lining, sometimes with a fluid cushion underneath, sometimes without.
Okay. And other small vessel issues.
Definitely. Things like small angiodysplastic lesions, those little clusters of blood vessels in the colon. And on the bleeding side, specifically vascular ectasias, these are just collections of fragile, leaky vessels.
Any classic examples of those?
Two big ones come to mind. First, radiation telangiectasia. You see this sometimes, maybe months or even years after someone's had radiation, say for prostate cancer. They can develop these tiny, fragile vessels in the rectum that bleed. APC is great for that.
Okay. It seals them off.
Exactly. The second one is JVE syndrome, gastric antral vascular ectasia. Lots of people know it as watermelon stomach.
Right, because of the appearance.
Yeah, you get these characteristic red stripes of dilated blood vessels in the stomach lining. Looks a bit like a watermelon rind. APC is really effective at treating those fragile vessels to control bleeding.
So the takeaway here is APC isn't a general fix-all. It's a specialized tool for specific, usually quite small vascular problems or superficial tissue ablation.
Precisely. It's about finesse.
All right, let's get into the mechanics. You called it non-contact thermal therapy. How does that actually work? How do you heat tissue without touching it?
Yeah, it's pretty clever. The APC system uses a special catheter that delivers two things simultaneously. Argon gas.
Okay, just plain argon.
Yep, inert argon gas. And it delivers a monopolar electrical current through a wire inside that catheter.
No polar, meaning the electricity needs a path back, right?
Exactly. We'll come back to that. But
Yeah.
the key is what happens at the tip. The argon gas flows out, and the electrical current ionizes that gas right as it exits the catheter.
Ionizes it, turns it into what?
It turns it into plasma. Think of plasma as like a super energized conductive gas. It's that argon plasma beam that actually carries the electrical energy across the small gap, maybe just a few millimeters from the catheter tip to the tissue surface.
So the plasma jumps the gap.
It literally does. And
Yeah.
when that plasma hits the tissue, the electrical energy converts to heat. And that's what causes the coagulation or the ablation effect.
And because it's a plasma beam, it can spread out a bit.
It does. It spreads laterally, which is great for treating broader, flatter areas, unlike just touching a point with a hot probe.
Okay, you mentioned monopolar current. That means we need a return path for the electricity. What's the external setup required?
Yeah, absolutely essential part. The neutral electrode, or what most people call the grounding pad or dispersive pad, this has to be placed on the patient, usually on a large muscle mass like the back or thigh.
Why there?
It provides a large surface area for the electrical current to safely return to the electrosurgical unit completing the circuit. Without that pad, or if it's not placed properly, the system won't work right, and worse, the current might try to find another way out, potentially causing burns elsewhere. It's a critical safety step.
Right. Completes the loop safely. Now, the delivery catheters themselves, Dr. Raju mentioned 3 types. Seems important to pick the right one.
Oh, definitely. You waste time and resources if you don't have the right catheter ready. The most common is the forward jet or axial beam. It shoots the plasma straight out the front. pretty standard.
Okay.
Then there's the side fire beam. As the name suggests, it directs the plasma out the side of the catheter tip. Useful for getting at lesions that are maybe at an awkward angle, tucked behind a fold, something like that.
Right, different angles for different jobs.
And the third is the circumferential beam. This one often has a ceramic tip, and it's designed to apply the energy in a circle. Think treating Barrett's esophagus circumferentially.
Gotcha. And these come in different sizes, too.
Yep, usually 7 French or 10 French diameter and different lengths. Often you just stock the longer colonoscopy length as it works for most situations.
Yeah.
And a little trick mentioned is just pressing the blue pedal briefly to check the gas is flowing before you start. You'll hear or see the gas hiss out.
Simple check. Okay, so we have the gas, the electricity, the right catheter, the grounding pad. But the real control and maybe the risk comes down to the settings on the machine. What are the key things the operator adjusts?
There are basically 3 main knobs you're turning, so to speak. First is the electrical power, set in watts. Second is the argon gas flow rate, usually in liters per minute.
Yeah.
And third, critically, is the duration, how long you actually press that activation pedal.
Okay, let's talk modes. The video mentioned 3 main ones, starting with forced APC.
Right. Force APC is kind of the default, the workhorse. When you press the pedal, it delivers a continuous stream of argon plasma. That's it. Simple, continuous energy delivery.
What kind of settings are typical there?
Oh, it varies, but maybe somewhere in the 15 to 50 watt range is common. And the gas flow, often around zero point 0.8 liters per minute, though it can go higher. The key is continuous as long as your foot's on the pedal.
Okay. Then there's pulsed APC. What's the difference?
Pulsed APC, again, as the name suggests, delivers the energy in short bursts or pulses. You might choose a specific pulse frequency, like pulsed 1 or pulsed 2. This can give a bit more control, maybe less charring, potentially useful for more delicate jobs.
A bit more finesse than just continuous power.
Exactly. And then there's the really clever one, precise APC.
Okay, what makes this one precise?
This mode tackles a really practical problem. Imagine you're trying to treat tissue in the colon and the patient is breathing, or maybe they shift slightly. That means the distance between your catheter tip and the tissue is constantly changing, even by millimeters.
Right, and you said the energy transfer depends on that distance.
Hugely. So if the distance varies, the amount of energy actually hitting the tissue varies, leading to an uneven effect. Maybe too much in one spot, not enough in another.
So precise APC fixes that.
It tries to. It uses some kind of feedback mechanism. The details are proprietary, I imagine, but it constantly measures or calculates that tip-to-tissue distance and automatically adjusts the power output in real time to keep the effect on the tissue consistent, even if the distance is fluctuating slightly.
Wow, okay. That's smart. It's like image stabilization, but for electrical energy delivery.
That's a good analogy, yeah. It helps take some operator variability out of the equation, especially in a dynamic environment like a moving bowel.
Now, let's nail down this duration factor. You mentioned watts, flow, and duration. Why is holding the pedal down longer potentially more dangerous than just cranking up the watts a bit?
It comes down to total energy delivered, which we measure in joules. Energy equals power multiplied by time. So let's say you're using 45 watts. If you apply that for just 1 second, you've delivered 45 joules of energy. But if you keep your foot down for 3 seconds, same power, 45 watts, you've now delivered 135 joules.
Triple the energy.
Triple the total energy, and that extra energy doesn't just stay on the surface, it penetrates deeper into the tissue. That's where the real danger lies, deeper thermal injury.
Okay, that leads us perfectly into the safety side. This deep thermal injury, it's a major concern, especially in thin-walled parts of the GI tract, like the cecum, right? And the scary part is, you might not see it happening during the procedure.
That is the absolute nightmare scenario. You can cause significant thermal damage down into the muscle layers without realizing it at the time. The surface might look okay, maybe a little white, but the heat has cooked deeper.
And then what happens?
The patient goes home, feels okay initially, but then hours, maybe even a day or two later, that damaged, weakened bowel wall can perforate. That's a delayed perforation, and it's a surgical emergency.
Wow, okay, so how do you prevent that? If you need enough energy to treat the surface lesion, but want to avoid cooking the muscle underneath.
The standard technique, and it's really crucial, is to create what's called a submucosal bleb, or cushion. Before you apply the APC, you inject saline, or sometimes a special viscous fluid, into the layer just beneath the surface you want to treat the submucosa.
Okay, lifting the target area up.
Exactly. It lifts the mucosal layer, creating this fluid cushion between the surface and the deeper muscle layer. That fluid is mostly water, and water is fantastic at absorbing heat.
Ah, so it acts like a heat sink.
Precisely. When the ATC energy hits the surface, a lot of that thermal energy gets absorbed by the fluid bleb, protecting the underlying muscle from getting too hot. It's a simple but incredibly effective safety measure.
Makes total sense. A literal protective cushion.
Mhm.
Are there other, maybe less dramatic, side effects or issues with using argon gas?
Yes, a very practical one is bloating. Argon gas is inert, which is good, but it's also non-absorbable by the body, unlike CO2, which is often used for insufflation.
So it just builds up.
It just builds up in the gut. If you're doing a longer procedure, the patient's bowel can get quite distended with all this trapped argon gas. It's uncomfortable for them afterwards, can cause pain and cramping.
What's the solution?
Constant vigilance by the endoscopist. You have to be actively suctioning out the gas throughout the procedure to try and keep the bowel decompressed and minimize that post-procedure discomfort.
Okay, diligent suctioning. Now, the last safety point from the video was maybe the most startling one.
Yeah.
The risk of explosion.
Yeah, seriously.
Yes, seriously. And this is why bowel prep is absolutely non-negotiable, even if you're only treating something seemingly small and localized, like those radiation telangiectasias in the very end of the rectum.
Why? If you're working way down low, why does the whole colon need to be clean?
Because of methane gas and potentially hydrogen gas as well. If the colon isn't properly cleaned out with a full bowel prep, there can be residual stool, and bacteria acting on that stool produce flammable gases, primarily methane.
APC uses an electrical current. Even if you're applying it in the rectum, that electrical energy has the potential to ignite any flammable gas present anywhere in the colon, particularly in the right colon where methane concentration can be highest.
So you could literally cause a colonic gas explosion.
It's rare, but it absolutely can happen, and the consequences can be devastating. That's why you need a full, thorough bowel prep, the kind you'd have for a colonoscopy, to eliminate that flammable gas risk before you introduce what is essentially an electrical spark into the environment.
Wow. That really underscores the importance of following prep instructions to the letter. It's not just about getting a good view.
Not at all. It's a fundamental safety requirement when using electrocautery or APC in the colon.
Okay, let's try and tie this all together then. From our deep dive today, drawing on Dr. Raju's work, we've learned that APC is this non-contact monopolar thermal therapy. It's not for everything, but it shines for small vessel bleeds, think AV, radiation changes, and for ablating residual tissue, like after polyp removal.
Right, precision work.
And the whole thing depends on having that complete monopolar circuit with the grounding pad. The operator needs to understand the different modes, especially things like precise APC for moving targets, and be really mindful of the energy settings, particularly duration.
Duration is key to controlling depth.
And then the critical safety protocols. Using that submucosal saline bleb as a heat shield to prevent delayed perforation, constantly suctioning the argon gas to avoid major bloating, and absolutely vital, insisting on a perfect bowel prep to remove any risk of methane explosion.
You've got it. It's a powerful tool, but one that demands respect and careful technique.
It really highlights this incredible tightrope walk in medicine, doesn't it? We saw how just an extra second or two on the pedal could be the difference between effective treatment and a dangerous deep injury, a delayed perforation.
It's a fine line sometimes.
It makes you think about that delicate balance, giving just enough energy or intervention to fix the problem, but staying below that tiny, almost imperceptible threshold that could cause a major unseen complication down the line. What other medical procedures operate on such a knife edge where success and danger are separated by milliseconds or millimeters?
That's a deep question. Lots of areas in surgery, radiation oncology. It's something clinicians grapple with constantly.
Definitely food for thought. Thanks for breaking that down for us.
My pleasure.
And thank you for joining us on the Deep Dive. We'll catch you next time.